Hi, this is Dr. Karen Riley, family physician, St. George, Utah, and I'm so excited today to have Dr. Rick Obray here with us. Dr. Obray is from Southwest Spine and Pain, and to give you a little bit of his background, he went to medical school and residency at Johns Hopkins University, and then a fellowship at Mayo Clinic. Returned to Johns Hopkins University for a fellowship in MRI, and then subsequently to Mayo Clinic for spine and pain. And that's actually what he does here in our community. And their clinic serves over 100,000 patient visits a year. They've been here for over 10 years, and I've had the privilege of working with him for the last 4 while I've been here in St. George. So today, the reason why I invited him is because I wanted us to have a little conversation about stem cell therapy. This is one of those questions I get asked frequently in my office, and because this is something that is not covered by insurance, I really want my patients to be well-informed consumers and be able to get the biggest bang for their buck. So just to begin with, first of all, what are stem cells? So stem cells, when an egg and a sperm meet, you have a cell that is created, and from there those cells will multiply into an embryo, and at that point those cells, each of them individually, are capable of basically forming any tissue type in the body. So that is the most base stem cell. So that's where the stem cells have originally been harvested from, but now we also have the pluripotent cells from other sources, and we'll talk a little bit about that if you want to go ahead, and I'll let you talk about the...
Sure. So there are several types of stem cells that are used currently in medicine. So like you mentioned, the pluripotent stem cell that comes from the embryo, so the developing embryo starts from a single cell organism, then expands into a full fetus, and then ultimately a full baby. That comes from a single cell. Now, those are kind of differentiated from embryonic stem cells from more supportive stem cells. So it turns out, as the baby's developing, there are also hundreds of millions of a different type of stem cell in the umbilical cord. Wharton's jelly is really rich in that are supportive of that developing fetus. Now, you can't take one of those stem cells and generate an entire fetus, but you can take those stem cells and they can differentiate into different tissue types if they're in the right environment. So in all the stem cell research that we're doing and work that we're doing has to do with non-embryonic stem cells. So we're using the support stem cells, and many of the also cells we use are adult stem cells that are harvested from bone marrow.
And that's going to be important as we talk about this with a little bit of different perspectives over the next few minutes, because needing to understand that different stem cell lines are going to be better for creating different types of tissue. So that we're going to come back to that question. So stem cells have been used for a long time in another form of arena that most people don't normally think about, and that is bone marrow transplant. And that's a little bit different than using embryonic tissue, because in that case you're actually using a stem cell specifically to blood cells, a hemopoietic line, which is the origin of the bone marrow and the blood cells in the body. So it's really not that foreign of a concept. That's been done for years and years and in a very safe environment. But sometimes we don't realize that that's actually been out there and something that we're a little more comfortable and familiar with. So along the same concept of different cell lines, when you hear about someone getting a bone marrow transplant, you also hear about them having to have a match. And that's because there are protein markers on our cells that identify our cells from somebody else's cells or the cell type. And so if you don't have as close of a match as possible, the body will see that as foreign and reject that cell. So that's something else I want you to kind of think about, because we're going to have to come back to that one as well. Yeah. Okay, so there's been a lot of controversy in the stem cell use arena. So some of that has been because of using embryonic cells. Part of the controversy has been, where do those embryos come from? So is it from in vitro fertilization of eggs that people have had because they wanted it for fertility issues, but then when they're done with their fertility needs, do we just let the eggs die, or do we use them to go on to something else? And if it's an embryo, is it something that has the full potential to go on to a human being? And so how do we handle that? So that's been one of the areas that have been under great controversy, and why that has had some issues with the progression of stem cell research in the past.
And the thing that's really interesting about that is, in the U.S. you can't use embryonic stem cells, so it's not available in the U.S. Now in Europe, particularly in England, they were using embryonic stem cells for certain types of research. And it turns out that one of the early uses were using them in spinal cord injury patients. Now, when you inject these embryonic stem cells from aborted fetuses or from embryos, they were causing tumors. So they're no longer looking at that as closely as they were. And then we discovered adult stem cells. So that was discovered by a researcher in Japan, actually won the Nobel Prize for that.
Kind of changed the whole
It changed
area.
everything because we learned there aren't just embryonic stem cells that can develop into things, but there's this whole world of support stem cells that can go on to generate. They can't form everything, but they can form in the right environment specific tissue types that can be very effective. So you don't have to use the embryonic stem cells per se. You can use these support stem cells in the musculoskeletal system, something called a mesenchymal stromal cell, or an MSC is a common abbreviation for that, that can be used to be very helpful, we think, early research suggests, in helping with musculoskeletal conditions.
And that seems to be one of the areas that is the highest focus in use right now. So we'll talk about that, and also in veterinary world how that's come about. Another controversy was concerns over cloning and using stem cells for cloning. There's a great sci-fi movie, if you haven't seen it. I don't know if you've seen that. The Island.
I haven't seen that.
Yes. So Ewan McGregor and Scarlett Johansson, if you're a ScarJo fan. And basically, the population would send their cells off to this island, and they would grow everybody, and they would implant memories into them.
Yeah. In case they needed certain body parts.
Exactly. Yeah. Something happened to them down the road, so they could harvest their body parts and kill them. So, kind of a fun side spin if you want to have a chance to look at that, just to think about something behind stem cells. And then concerns over aggressive marketing with cord blood from umbilical cords, and who should get that, and who has rights to that, and how that should be used, and how much do we pay for that. So if you want to talk a little about that, I know you've mentioned that before.
So we have. So one of the potentials of a source of stem cells for someone, for instance, are their umbilical cells when they're born, as well as their cord blood. Turns out that the placenta umbilical cord is one of the richest sources of stem cells in the body by far. And there are 500 million cells that can be isolated from the placenta alone. And they're all different types of stem cells. Now, when we age, there's always things older in life that potentially we could use these stem cells for. But when we're young, there was recently a phase 2 study from Duke that used umbilical cord stem cells that were cultured and then infused back into autistic kids that had pretty dramatic results in both socialization and verbalization. That's a phase 2 study performed at Duke University. Historically, most of cord blood storage has been used for blood disorders in kids. So leukemia is something where they needed to replace their marrow. They developed a marrow or a bloodline cancer. They had to wipe it out and then reconstitute it. So your cord blood is perfect for that, because your cord blood is rich in the hematopoietic stem cells that can be used to reconstitute someone's marrow, as well as MSCs that can be used as well. So the challenge was for cord blood storage, the cost of doing that traditionally has been very expensive, up to $5,000 initial fee, and then there's usually a yearly maintenance fee. Recently been involved.
Because if you don't maintain it,
they
take it out of the lab freezer and it dies.
So if you don't freeze these cells at 200 degrees below zero, then they die very quickly within days, sometimes within hours.
So you could have invested thousands and thousands of dollars in it and be gone just that fast.
You could. So obviously there's risks about how do you keep these cells over long periods of time. Having seen the research that's coming, there's research being conducted in almost every aspect of medicine. They're using stem cells for treating premature babies because they're anti-inflammatories. So when you infuse or inhale stem cells into a premature infant, one of the reasons that they can't survive when they're too little is they get so much scarring in their lungs from oxygenation. Well, these stem cells are incredibly anti-inflammatory, so you can stop the scarring from these premature infants. It's been used for autism, which we talked about. They've been used to treat cerebral palsy with pretty significant effects. They've been used to treat MS. There was a recent study that documented for MS patients that were treated with high-dose stem cell infusions, their recurrence rate in the relapsing remitting form went from over 5 years from 90% to about 10%. which
And that's
was
the most
pretty
aggressive
dramatic.
form of MS, relapsing
It
and
is.
remitting. So that's a pretty significant difference in somebody's quality of life.
And that's promising. Now, that's an early study. That's promising. My father has multiple sclerosis, so I watched that pretty closely. But and they're using them for cancer treatment. They're experimenting with those. They're using them for tissue transplant. So it turns out if you receive a tissue transplant and you infuse high doses of mesenchymal stem cells, you can actually, the body will tolerate the transplant without rejecting it. And one of the unique things about stem cells is they don't, when they're early, like embryonic stem or umbilical cord stem cells, they don't have antigens. So they don't cause an allergic reaction like you would in an adult cell.
So as we talked about those markers, having to have that perfect match, in that case you don't have to worry about that because you're not going to react to it that same way.
They're naive enough that they haven't formed their surface antigens yet, so they don't have that potential for rejection. Now, it turns out if you culture those stem cells, culturing just means you grow them and expand those cell lines at a certain period of time, 7, 8 replications,
growth later.
they will start to form antigens, and then there's a potential for a reaction. So
I wanted to bring that up because a lot of times we assume because it's our own cells that if we put it back into us, there's no risk for a reaction or rejection or problem that way. But that's something that I wanted to go over, is that we want to make that clear that just because it's your cell line that might be harvested doesn't mean that you can't reject it or have a reaction to it, almost like an autoimmune reaction even.
it can potentially, if you take your cells out and re-inject them without manipulating them and changing them, the reaction's pretty small. Because you're literally, it's almost like taking blood out and then reinfusing it back in. However, if you take the cells out of you and you culture them or you manipulate them or you enzymatically process them, etc., you're not sure that cell coming back into you is the same as your native cell, because there can be changes that occur when that happens, and that's a good point.
Okay. So Rick talked about several of the current uses. I just wanted to go over a few other ones that we've seen mentioned in the literature. So he talked about neurodegenerative diseases like MS. It's also been used in Parkinson's disease, Lou Gehrig's disease or ALS, Alzheimer's. There's a lot of promising work coming out with Alzheimer's as a degenerative disease, which would be amazing. Also, as you mentioned, spinal cord, traumatic neurological injuries, other degenerative conditions, cardiac conditions, so remodeling of heart muscle, and then pancreatic cells. This has actually been in development since I was in residency many years ago. Trying to regenerate islet B cells for pancreatic patients, and even putting them someplace else in the body, such as like in the forearm or even in the fat of the belly, not necessarily have to put them in the pancreas. I also saw research on cochlear hair cells for patients who have had hearing loss and are deaf. Corneal cells for problems with eye damage to the cornea. Instead of doing a corneal transplant, you can do, and they're using with assistance of transplant to make the transplant heal better as well. So do a repair, reduce scarring, yeah. And then wound healing, scarring in general, being used more and more because of that anti-inflammatory effect that you talked about. And then also some use with treatment HIV and AIDS. But the majority is still in musculoskeletal world.
In musculoskeletal, because it's kind of low-hanging fruit, and we're just learning the capabilities of what these cells can do. But it makes sense that in some ways you think, what were we thinking for so long? Because the first 9 months of life, in many ways, are the most critical. If you get scarring, you get damage, you get destruction, those first 9 months of life, it changes the whole course of life. So this apparatus of the placenta with the developing fetus and the umbilical cord, I think of it as tremendous amount of energy reserves to make sure everything goes right. And by the way, mom is living, getting sick, having infections and everything else, that fetus has to be able to deal with that and not hinder development. So the body uses a tremendous amount of resources. It's that mystery of life in the first 9 months to try to make sure everything goes as well as it possibly can. And one of the interesting things about a developing fetus, if you actually take a fetus and you can do surgery when they're in utero, and you do surgery and you layer that surgical scar with high concentration of stem cells, when they're born there is no scar.
Which is amazing.
Which is pretty incredible.
Yeah.
So the wound applications we've seen for burn victims and so forth, they've been using amniotic membrane, which is the inner membrane of the developing fetus, and the covering, the placenta, basically, for wound victims and burn victims for 20 years or so.
And you know that plasticity that you see in that healing and growth even extends for the early years after. I mean, kids with head injuries and trauma, most of the time you can't tell. There's so much recovery that takes place and how amazing the body is at regeneration. So again, it just goes to show how much this research is changing the future of medicine and recognizing our own natural capabilities that we have within us. So some of the other things you talked about, using support cells, we're starting to see more research also in harvesting the chemical mediators, the exosomes, as a support for those same conditions, inflammation, etc., that it doesn't necessarily always have to be just the stem cell itself.
It doesn't, and one of the interesting things about that is, so when they do research and they look at how these stem cells are interacting, say in autism, for instance, there's several ways a stem cell can interact and help the body do things when you inject it or infuse it back into a patient. But most of the effect seems to be occurring, especially in the brain, is something called the Paracrine Effect. So it's not so much the cell interacting directly, but the cell changing signaling cascades, and those signaling cascades then activating your own stem cells to then become active and do their job. One of the things that a lot of researchers believe that the MSCs, in particular the anti-inflammatory cells, that are kind of the support cells in uterus and also in our own bodies, they help bring things back into equilibrium. So for instance, say someone has had, and this is theory, hasn't been proven yet, although there's some evidence to suggest it, that when we get in a chronic disease state, things are out of balance. So for instance, your knee, you get an inflamed state like with rheumatoid arthritis, the balance between repair and destruction is out of alignment, and that favors destruction, then you get deterioration of the joint. Some people believe that these MSCs help maintain that balance. So they stop the anti-inflammatory state, or the inflammatory state, and make it a less inflammatory state, and then that brings things back into alignment between repair and destruction. And if you look at some of the orthopedic literature, particularly coming out of France, there's a little orthopedic surgeon called Dr. Herniga, who's really pioneered a lot of the bone marrow aspirate treatments. He showed that as we age and with more severe cases of osteoarthritis, these support MSCs in the distal long bones adjacent to the joint are in low numbers. So the worse the arthritis, the lower the numbers of his MSCs, and that's led to some of his treatments that he's pioneered using bone marrow stem cell treatments to treat joint disease and so forth.
Boost the MSCs in the area and you'll
boost it,
rebalance.
activated them, and then kind of bring things back into alignment so that repair and destructive forces are more equal.
And it's interesting because that concept is now being recognized more and more in the body in general. I try to teach my patients that in regards to diabetes and in regards to just general healthy eating and living, because when we eat foods that trigger inflammation in our body all the time, we're causing that system-wide destructive process to take place, causing everything to be out of balance, like you said, and that inflammation is going to contribute to disease processes like atherosclerosis, so potential heart disease and buildup of plaque in the body. And we don't think about it as such a simplistic concept of inflammation causing so much damage, but if you actually look back at almost every disease process, it usually goes back to inflammation. Yeah, so that is so important. Okay, so let's kind of change a little bit. So let's talk about more how when you harvest a stem line, as you mentioned before, you can't always use every line for every type of tissue growth.
Correct.
So how do you know where you're going to get that best bang for your buck? So how do you know which lines you should be using for what?
And that's a great question. So when we look at stem cell therapies, there are several types of quote-unquote stem cell therapies. And then there's other types of therapies that people associate with stem cell therapies, but really truly aren't stem cell therapies. And a lot of this has to do with regulation in the FDA and how the FDA regulates manufacturers, and then how the state medical boards regulate medical practice within a state. So it's probably good to talk about what are the different types of therapies that are available right now, because I think it'll answer a lot of those questions. So when you think about using these stem cells to be treated, the ideal way to do that is in a study we participated in recently. They say, okay, we think MSCs, mesenchymal stromal cells, or mesenchymal stem cells are important for helping inflammation. So say you have degenerative disc disease, which is a study that we were recently involved in. You say, we think these cells will work. We think this concentration of cells will work. We say, okay, we're going to identify 350 patients. We're going to give half the patients the stem cell therapy, and we're going to give the other half a placebo. And then the doctor's not going to know who's getting what, and the patient's not going to know who's getting what. And we're going to follow those patients for 12 to 24 months. And at the end, we're going to document how they did, pain control, or pain relief, functional improvement, all those things. And then we'll see at the end if there's a difference between the two groups. So that's what we call randomized double-blind controlled trial, which is level 1 evidence. And that's historically as medicine has kind of worked, right? And we just completed enrollment in a study, a national study, that's exactly what they did. We're looking at using cultured MSC, so they took adult marrow cells from a healthy 18-year-old. They grew them in the lab in the millions, and then they injected those cells back into patients, and some of them got the cells, and some of them got the placebo, which is basically just a benign type
solution.
Of injection,
okay.
As much as they can make.
So I'm going to hold you down for a second there.
Mm-hmm.
So it was an allograft, so it was from somebody besides
It was
themselves.
an allograft, meaning, not the patient, which is an autograft, but an allograft, yep.
And when they harvested them from this 18-year-old, were they harvesting them from bone marrow?
They harvest them from bone marrow. And the reason they did is there's some suggestion in the musculoskeletal system that the bone marrow MSC it's already kind of gone down the pathway of what it's going to be, and that pathway is something within the musculoskeletal system. So bone cells, ligament cells, tendon cells, something in the musculoskeletal system, which if you're dealing with a musculoskeletal condition, that's the stem cell that they theorize that's the one they want. To differentiate from a hematopoietic stem cell, which has a very different function. That's a bloodline cell.
Right.
So that's why they chose that cell, and that's why they did the research that way.
And then I also see a lot of harvesting they talk about doing from fat sources. So is there a differentiation on the lines that are going to be musculoskeletal from a fat source versus the bone?
A little bit. Now, part of the reason they're going after fat is because it has higher concentration of MSC. So if you look at MSCs, they're actually in a slightly higher concentration in fat or adipose tissue than they are in marrow. But part of it, what is used, comes down to regulation. So the FDA regulates all of this in what's called tissue allograft. There's a federal statute that talks about how we use medical treatments, and there's two major pathways that they regulate. One is what's called the 351 pathway, which is just how you would regulate a drug. So Vioxx, anything that's prescription strength or been shown to have a certain indication goes down a 351 pathway. And what that usually entails, toxicology studies, make sure it's not bad for patients. Then animal studies to make sure initially before you test on humans that they have animal models, right?
And it should do what we claim it says it's going to do.
Yeah, and then you have small safety studies. And then once you prove that it's safe and not hurting things, then you do larger studies to show efficacy that's effective. And then generally you get large double-blind randomized controlled trials proving in large numbers that it's effective. And then if all those steps work out, and that's about a $50 million to $100 million process, sometimes $500 million process, then the FDA will allow those manufacturers to say, yep, this drug can be used for this indication.
It's interesting. I'm glad that you brought that up because so many times, you hear patients frustrated with the insurance companies and the cost of medications when they first come to market. And believe me, I completely understand. But they don't realize the cost that goes into that research and development of bringing a drug to market and the amount of regulation that the FDA puts a company through versus saying something that comes out in the holistic world, like a supplement that has
it's pretty much
none of that, completely unregulated. And I have another video that talks about that.
And they're not supposed to make claims. The difference is if you go through that process, you can make a claim. Mm-hmm. Now, if you don't go through that process, you can say, this is in there, and this has been shown to have an effect, but who knows what it does in the body.
Right.
And that's a clear differentiator. But that's a drug pathway, the 351 pathway. Now, the other pathway that's important in this space is something called the 361 pathway, and that's a tissue allograft pathway. Now, that's an example.
It'll kick off because of the memory, so we'll have to record it as a full
Sure.
file.
No problem.
Okay, so start with recently had your ACL.
So recently I had an ACL injury, and you can take an ACL from a cadaver or a tissue donor, and then that can be used for an ACL repair. And that's the 361 pathway, and that doesn't require going down the same regulatory pathway as a drug, because it's assumed that it's going to be doing the same function in the recipient as it was in the donor. Now, with stem cell, these tissue allograft products, they're pretty tightly regulated as far as how you procure those tissues, how those tissues are tested to make sure they're safe. And there's a whole regulatory framework that goes around those tissue allograft products. Now with umbilical stem cell products, it's a little different. It's not truly a 351 pathway, but it's also a little different than a 361 pathway. Now you can make very strong arguments that these are supportive cells in the developing fetus, and they're having a supportive role in the joint to help lubricate and mechanically stabilize and so forth. But again, the FDA is trying to figure out, where do we put these? Do we do a new category? Are they truly 351? Are they truly 361? And that's a very interesting process that we watch very closely to make sure that we're doing what's within the guidelines that are done. And that's really, the FDA does not mandate medical practice. They mandate the manufacturers, but the manufacturers are the ones producing the products that physicians then use as they feel appropriate.
And it's interesting because a lot of the research I was looking at has been being done in the veterinary world in musculoskeletal stuff, especially racehorses, for the same reason. Like you mentioned, the ACL, actually doing regeneration of horse injuries, but doing the exact same thing that we're now extrapolating and doing in humans. Yeah.
And it's a very important point because it's a little bit of the Wild West right now, and using these tissue allograft injections. Now, you're not even really a tissue allograft you're not supposed to call it a stem cell procedure. It's a tissue allograft procedure, which designates it as a 361 pathway. The reason is because we don't have phase 1, phase 2, phase 3 trials like we do in the 351 pathway. So when you hear someone advertising stem cell therapy with umbilical cells, they either don't understand the regulatory environment or there's some misconception, because that requires a 351 pathway. If you're using cellular therapy, that's a 351 pathway. If you're using tissue allograft therapy, that's a 361 pathway.
So that's a great segue into some of the questions that I have about what I see out there in different clinics and marketing, and trying to make sure that we're keeping patients well educated and informed, and that they, like I said, are getting the best bang for their buck and being a smart consumer. So right now, the treatments that are officially approved for actual stem cell, I read bone marrow.
Correct.
And immunodeficiencies.
Correct.
And then bone replacement, corneas, and skin.
Correct.
But outside of that, everything else at this point is considered experimental.
Experimental and certainly unproven. Now, there are certain studies that have been done, case review series. So the way it works is the FDA regulates the manufacturers. That's all they do. They don't regulate medical practice. That's done by the state medical boards. And the state medical board in Utah, there's something called the Alternative Medicine Practice Act that gives providers the ability to treat patients how they think they should, even if it's quote-unquote an alternative treatment like tissue allograft therapy, as long as they meet very strict requirements for informed consent, can make certain claims. So when I see some of the things I see going on, I just chuckle, because you can't say this is going to cure everything in the absence of evidence, and we don't have that evidence. Now, in the issue of bone marrow aspirate therapy, there are several trials that have been done. The most recent one that I saw was a presentation at a national meeting by Dr. Hernigo. He had 40 patients, both knees were bad, right and left knees. All 40 of those patients underwent therapy on both knees. One knee they did a total knee replacement. The other knee they did a bone marrow aspirate procedure. Quote unquote stem cell, but it's really a bone marrow aspirate. Now there are stem cells in that procedure, and that's what they were looking at. Now, and then they followed those patients for anywhere from 5 to 16 years, up to 16 years.
Which is amazing length of
It's
time.
a long
under study.
time. And these were patients in their 80s, and he looked at functional improvement.
80s.
Pain.
Anybody can still get some recovery here.
So, and looked at recovery rates, surgical, resurgical rates. Turns out there were 3 patients that had total knees that had to have another surgery. He looked at complications. There were 3 life-threatening complications, I think, in the total knee group. There were no life-threatening complications in the stem cell procedure group. At the end of the day, he asked them, what would you do again? Would you do total knee, or would you do a bone marrow aspirate procedure first? And it turns out that 28 of the 40 patients said they would do a bone marrow aspirate procedure before they would do a total knee. And what's interesting, of the 40 knees that were treated with a bone marrow aspirate procedure, only one of them went on to have a total knee. That tells you one of 2 things. Either it was effective and they had good pain control and functional improvement, or they weren't overwhelmed with their total knee and they said, I'll take what I have. So it says, and there's probably a mix of both of those. But that's a study.
Or they were too old to have the surgery.
Exactly, or too old to have surgery. But that's an example of a study that was done using autologous therapy in bone marrow, and a lot of times that's quoted in the literature.
But again, that was a study versus just
making a
anybody being in their clinic, shooting this wherever they want, making a claim that it's going to regenerate any tissue they want. So interesting. You and I were talking about a recent cease and desist, and someone that got arrested in medicine for injecting in eyes, if I remember right.
Correct.
Yeah.
So there's a stem cell clinics that were doing adipose injections into eyes, and there's a case in Florida where someone went blind following an adipose injection. Now the FDA, again, they just regulate manufacturers. So the cease and desist was partly towards the manufacturers. But if there's damage and you're hurting patients, and they can't do a cease and desist. And now what generally happens is the state medical board will do an investigation, and they'll pull the medical license of a physician who's doing these therapies or making false claims. It really comes down to making false claims, reporting adverse events, appropriate informed consent, and that's so. But the state medical board is responsible for outside of criminal charges. Now, sometimes there can be criminal charges, but outside of criminal charges, the state medical board will regulate licensure.
Which unfortunately, honestly, in my experience, usually doesn't happen until after there's a disaster and after the fact. Like, they're usually not monitoring what's going on in different clinics or the advertisement or literature that's being put out there, and coming and saying, no, you can't do that. That's incorrect use, or you shouldn't be doing this. That doesn't happen. And so that's an unfortunate side of regulating ourselves, is that that's usually not monitored closely enough.
Yeah, in our generation, so when I trained in medical school, I mean, it was so, and particularly at Hopkins, I mean, it was so evidence-based. Everything we did was evidence-based. You looked at the studies showed you what worked, what didn't work, and that's what you did. And having been out, this is the first time in my career where I've seen patients driving a therapy. So I'll have, hypothetically, not a true patient, but I'll have a patient comes in and says, hey, doc, I'm going to Mexico, I'm going to get a bovine stem cell injection. And, well, how much is it? Well, it's 20 grand.
Mexico world.
But I think it will work, and, I'm desperate, and what do you think? And I'm like, well, bovine's a cow cell, which...
Not even human.
I mean, hopefully it won't hurt you, but it's very likely to hurt you, because your body, your immune system is going to react to those foreign cells, the antigens, and it's not even human. So, and there can be diseases and so forth. So, part of it,
that inflammation process that we talked about, not only may it not come even close to helping and doing what you want it to do, but even make your situation worse, because now that area is going to be even more inflamed and being caustic from that injection.
And part of the reason we got involved in this space, because they're like, well, okay, you just told me that you came from an evidence-based background, and the public is pushing for these therapies that lack evidence. So, Dr. Obray, what are you doing in this space? And sometimes I ask myself, but part of it was, I have a background in biochemistry. I did a master's in biochemistry before I went to medical school, and I did a ton of research when I was at Hopkins. And so I'm familiar with the cell biology behind what's going on. And then you see it. I mean, I remember when we were in that randomized double-blind controlled trial, and we saw the impact of injected stem cells in an animal model, and what that did to heal the cell, to heal the disc. And it was dramatic. I mean, it was like a light bulb moment.
So it's kind of hard not want to help patients in an appropriate manner when you know that you can see that working.
And part of the problem is, if we're silent, if I'm a medical doctor and I'm silent and I have no voice, and someone down the street is making outrageous claims and I'm quiet, it's my responsibility to educate the public and say, look, if you're going to do this, and you're willing to take the risk, and everyone takes a risk because it's unproven, right? You risk your money, and you risk an adverse event. If you're willing to do that, let's try to do it as safely as we can, and let's use the evidence that's available. Now, there's case series, and at least know what we're doing, so we make it the most likely to be successful. Because I can tell you, if you go get a bovine stem cell injection, it's not going to help you. Yeah. And if it does, it's a placebo.
Right. And that's exactly why you're here today and not someone else, because knowing your background, I wanted my patients to have the right information and a good resource that they can turn to here in our St. George area to make sure they're getting the right thing. Because I've seen advertisement from holistic or alternative medicine arenas. Yeah. I've seen advertisement from some chiropractor clinics, and I'm always like, oh, okay, I know they probably are not using the right lines or being as well informed as they probably should be. So can you tell us actually what process people will go through if they come to your clinic. So how many visits do they usually have?
Yeah.
Where you're getting your cell lines from? Why are you using those particular cell lines? Do we harvest from the patient? When do they have to come back and get it done? How are they actually being injected? What kind of recovery and how long is it going to take to see an improvement in their outcomes?
Yeah, there's 3 ways that we're involved in really tissue allograft and some stem cell therapies, however you want to talk about it. We do research. So like I said, we were in a national FDA-approved, double-blind, randomized control trial looking at use of stem cells in discs. So sometimes when we have those studies, patients, if they're willing to be a guinea pig, they can sign up for those studies and they can be treated as part of that study protocol.
And if they're in a study protocol, are they getting everything for free?
Yes, generally those studies are funded by the company that's sponsoring the research.
Okay.
And in fact, sometimes they can be reimbursed for their time. So that's the standard of care for research. So that's one way you can get these treatments. Now, remember, a third of those, and sometimes up to half, are going to get a placebo.
So may not do what they're
So you may go through that study for 2 years, and you were the placebo, and it didn't work, and you're part of that study. So that's the downside of being the guinea pig. The upside
great part is now you have the data from the study, so they can go back and get
the right thing done. A lot of times at the end, if the study's effective, then they offer that effective therapy to those patients that were the placebo.
That's a great bonus.
So that's one way to do that. And we're active in research, and our clinics do a lot of research for that reason, because we want to push the field forward. Now, there's 3 other ways you can get stem cells. Now, you can get what's called an autologous stem cell injection or autologous tissue allograft, which is the bone marrow.
Now, it's your bone marrow, not someone else's.
It's your bone marrow. So that's a surgical procedure. It's not very painful. It takes about, I used to run the bone, when I was a fellow at Johns Hopkins, I used to run the bone biopsy service. I've done a lot of bone biopsies. So for someone who knows what they're doing, it takes about a 5-minute procedure. It's not very painful if you know what you're doing. And then what you do is there's a way to maximize the number of MSCs you pull from the bone marrow. You can't manipulate them, you can't grow them. Usually you isolate them and then you re-inject them. Sometimes
so that
you concentrate
same day,
them.
you're going to do the bone marrow aspirate and inject it right
back in. And the FDA will allow you to do that as long as you meet those guidelines. Now that's not usually,
as we talked about, that's the least likely to cause a problem because
it's your own cells.
Manipulated, right?
It's not manipulated. You're not culturing these cells. And that's probably the safest, assuming that someone knows how to do that procedure. Now, it seems easy, and it takes about 5 minutes to do it, but I've done 30,000 procedures. So if someone's taking a weekend course and they're doing bone marrow, then there can be serious complications, bleeding, serious nerve injury. You can get puncturing of the abdominal cavity. So it's all relative, but if in the right hands, that can be. But that's something that usually is not done by a naturopath. It's usually done in the setting of someone who's well-trained, either in surgery or interventional therapy. Should be, because the scare factor for the provider is higher unless they have that skill set. So bone marrow aspirate, there's some, usually small case series, 20 to 40 patients that they've done and shown that there's efficacy. We've seen that for knees. We've seen that for rotator cuff repair. There was a very good study done by the same little orthopedic guy in France where they looked at stem cell in combination with rotator cuff repair and had dramatic reductions in failure rates. That's very interesting. Hospital for Special Surgery in New York is using that. Mayo Clinic is adopting that. Most of the big sports medicine centers in the country are now offering bone marrow at this time.
Interestingly, I did a report on another video about outcomes on subacromial surgeries, surgical surgeries, and that they're actually showing that there's really no effectiveness. And so this would be a great alternative for those patients who are looking for something different to be done. Like they're in pain, they need something. Anti-inflammatories and pain medications aren't the answer, but they could potentially have an alternative.
And I look at it as part of the treatment algorithm, right? I look at it as when a patient comes to see me and say they have knee pain, and they'll say, okay, doc, I have knee pain. First thing we do is get a diagnosis. So we're not just whipping out the needle, injecting stem cells, and we'll see you in a month, right? We get x-rays. If appropriate, we get MRIs. We diagnose what the problem is, make sure we know what it is. Is it a Cartilage defect? Is there instability? Is it ligamentous injury? And part of that is my musculoskeletal background in MRI. So we get pretty good at diagnosing what the problem is. Once we know what the problem is, and we say, okay, this is the standard treatments that are available. We can try cortisone injections, which is an anti-inflammatory effect. We can try hyaluronic acid, which is a lubricant that's used in the joint.
I describe to patients it's like re-lubricating
the
bearings in your joint case.
And there's some evidence that those therapies are effective. Then we talk about ligamentous repair, like an ACL repair, right? or sometimes the knee is destroyed enough that we talk about total knees, right? And total knee is a proven therapy done by an orthopedist that knows what they're doing, very good. That can be very good outcomes. Now in our treatment algorithm, we have the stem cell therapy. So where does the stem cell therapy fit? Well, the problem with stem cell or tissue allograft therapy, right? See, I made the same mistake. Tissue allograft, quote, stem cell therapy, is that it's not covered by insurance. All these other standard of care therapies are.
Right.
And because it's not covered by insurance, it can be expensive. So I think the average stem cell cost across the country, it ranges from about $3,000 to about $5,000. I have patients that have been charged $20,000, that some of my patients that have come from California, mostly Southern California, Beverly Hills area. So there's a range. If you get below a certain price target, I start getting nervous because I'm like, okay, what are you injecting?
Right. Because
one of the biggest risks with these types of procedures is that the product is safe. And to make sure you get umbilical cord product and it's safe, well, you have to test the mother. You have to have full medical history plus blood testing for the mother. And then once you acquire the placental tissue, it has to be by the American Association of Tissue Bank guidelines. There's certain regulations that have to be done. Then you have to take the samples, make sure they're pure, they're not contaminated with bacteria. You have to test them for bacterial contaminants, and then you test them for all virus contaminants. Once that testing comes back, and you store them at 200 degrees below zero, and they've shown to be safe, just like a blood transfusion, then a doctor can do what they want with those.
Yeah, I was going to bring that up because, we regulate our blood banks so
Right.
meticulously for all those things. And so that tissue process has to go through that same condition.
And it should. And the companies that do it legitimately do that. Now, before...
Which is a price. There's a price
Which is a price to that. So when the price gets too low, you're then diluting it down to, I'm not sure what you're getting, right? You might be getting 1/10 of what you really need.
And mostly saline or something
Right.
else.
And then you're hoping for a placebo effect or someone skirting the recommendation. So if you don't test for viruses, if you don't test for bacteria, if you acquire cells from who knows where, sometimes Mexico, then what are you really getting? And that's where the risk comes into play. Under the right circumstances, if someone adheres to the AATB guidelines, just like for blood transfusions, the FDA says for a blood transfusion, the risk of infectious disease is about 1 in a million. So pretty low. It's not zero, but it's pretty low. Now, there still may be pathogens that we don't know about, right? Viruses and so forth, we don't know
That we
about.
can't screen for.
And that's the inherent risk that you just have to be comfortable with. But the key for a consumer, if I'm a patient, and I've injected stem cells into my own knee from umbilical cord products, is that you got to know where those tissues are coming from.
And that's something that when I've had patients tell me that they're going to alternative clinics, I ask them, do you know where your stem cell line is coming from? And they usually give me a blank stare, like, what are you even talking about? And so that always raises a major red flag for me because I'm like, they haven't even had this conversation with the provider.
And that's a problem. So for me, when we started doing this, the first thing I did was went and talked to the medical board. This was a long time ago, before anybody was really doing anything, which I always chuckle because I see clinics saying we've been doing them longer. Like we've been doing research in stem cells for a long time. So I went to the state medical board and said, this is what we're talking about. What do you think about this? And they said, well, what is it? So we talked about what it was. And they said, yes, we think it's fine as long as you have good informed consent. Now, good informed consent means you're having a discussion with the patient about the risk benefits alternatives.
Right, including where those
cells come from. So if you're not, as a patient, if they're not telling you that, that's not informed consent. That's not appropriate informed consent. So when I started doing this, the other thing I did is I visited every clinic that we ever injected product from. I went to Phoenix, I went to Salt Lake, I went around the country looking at and I looked at their labs. I talked to their research directors. And if they didn't have a research director with a PhD in cell biology or cell biochemistry, that was a major red flag for me. Because you can't be in this space unless you understand the science of it. And then I saw crazy things. I saw a clinic, I kid you not, was manufacturing stem cells in a warehouse garage with a motorcycle there and a hood stacked in the middle. And they were buying PCP pipe from Home Depot to store the cells and go. I was like, are you out of your mind? There's no way I'm going to inject that into my patient.
That's just waiting for a disaster.
But the problem is it's hard to regulate that. And they're popping up everywhere. And the providers are like, well, I can charge $3,000 and they're telling me it works. But you have to do the due diligence behind it to make sure. And with the company that we worked with, I know the medical director. I know how they review the patient records. I know they're audited by FDA. I know I've seen those audit logs. I know the manufacturing process.
Most clinics or providers,
but you have to
as
do
an
that.
End product, are actually doing that kind of due diligence that you have done.
You have to do that because as a physician, I don't care who you are, your number one responsibility is to keep your patients safe.
Right.
Now I can't tell them these tissue allograft injections are going to be 100% safe.
Right.
And that's part of the informed consent process. I can say, this is what we know, this is what we don't know. You have to be comfortable with some degree of uncertainty. And even when I injected myself, believe me, it came up in my mind.
You have to think about it.
I'm thinking, is that medical director sleeping when he's reviewing those records?
Right.
How close is he watching that?
Or what can we not screen for that might still be in there?
Because there are things, but and it's risk reward. Now, when I think of alternative therapies, I think of, okay, what's the risk of a total knee replacement? What's the risk of blood transfusion? And in the study I told you with the patients in their 80s, the transfusion rate was 30%. What's the risk?
They had higher risk probably from that transfusion than probably actually did from their stem cells.
Correct. So it's all about weighing pros and cons. And when you make treatment decisions, if you're not weighing pros and cons, then you're doing your patients a disservice. So we try to do that.
Now you said there's a third way that you guys do it in your clinic.
So
what's
the third way, so we talked about bone marrow where we take a needle, and that's about a 5-minute procedure. It takes about an hour to do that whole thing, and it requires being in a surgical or procedural suite with sterile technique and all that. The third way you can do that is with these tissue allograft products, and that's the umbilical products,
what
that's
were you
the
just talking
placental
about.
products. Yeah, so that's the third way, and that's the FDA regulates those manufacturers relatively closely, but they really regulate it when there's a problem. So,
which is kind of like I
and
said
when the
about
sun
the
is
state
shining
boards.
and everybody's happy, no one's really looking.
Right.
When there's a problem, I guarantee you everyone's going to look with a microscope. And that's what happened in the Florida clinics when the patient went blind. The patient did not feel they had informed consent. Who knows? And they had a very bad outcome. So I tell my patients, look, I'm not going to do this for you. I'm not pressuring my patients to do this. And I think if you talk to my patients, they'll tell you that. But I'm providing that service for them with informed consent so they understand. Now, it doesn't mean I don't believe this is a very promising therapy. I think this is going to change every aspect of medicine. We talked about some of the studies, and there are more and more coming out. I think this, at the least, is going to be potentially a very good replacement for things like hyaluronic acid and cortisone, which is just really dampening inflammation, to having a major impact on major surgeries.
Right. Well, and this is so minimally invasive compared to doing a surgery. So we talked about those 80-year-old patients probably may not have gone through surgery because they may have been too old to do so. At this point, anybody of any age could potentially benefit because it's not going to have a significant surgical risk or downtime.
Correct. And it gives patients hope. And look, I take care of lots of patients, and about 30% of the patients in my practice have had prior major surgery and have moderate to severe chronic pain from that. So we're always looking for ways that are less invasive, that can get at healing and creating balance within the body, not just treating the downstream effect. So stopping or slowing the aging process. So we keep that repair destruction.
We're never going to stop it completely.
No, but instead of deteriorating our knees like this, maybe we can deteriorate the knees like this. And that's the hope, is that we can get to a point where the research suggests that and then insurance will cover it. Now the problem right now is the cost, and that's a significant barrier.
And insurances aren't covering it because?
They're not covering it because, look, I wouldn't cover it if I was unsure either, because there's no evidence. So if you want me to pay for this, one, show me it's safe, and two, show me that it works.
But that's coming enough. I mean, just like the study.
It's getting more. So I have had insurers pay for these procedures, particularly in the bone marrow space, because they feel like there's enough safety data out there that they feel comfortable. And look, you can do a $4,000 bone marrow aspirate procedure or a $30,000 knee replacement.
Right.
So there is a financial incentive for insurance just to find cheaper ways to do this, because they save money. We all save money. So, and that will come. My goal and my hope is that the prices are going to come down. I mean, there's a limit to what you can charge. Ironically, though, and it's the craziest thing, sometimes, because we try to lower our prices, is to get them to where it's more available for everyone, right? Because there's nothing worse than having someone come in, you feel like this is a therapy that could potentially help them, and it's cost prohibitive. That doesn't, as a physician, that's very
right. And instead, they're going to get a $30,000 surgery because insurance will pay for that.
Correct.
Right?
And they may not be a great candidate for surgery, with bad outcomes, everything else. But that's just the world we live in right now, and we're working to try to do that. I do consulting work for several stem cell companies. I've founded several companies that deal in this space to try to help get better products that are more cost effective and less risk.
But regardless, there's always going to be a cut. Like there's going to be a point where they just literally can't go below.
That's right.
Because if, like you said, if you want a clean line, a pure product, safety tested,
it's like a blood
just
transfusion. There is a cost, even if patients give their blood, there's a cost of making sure it's safe. There's a processing cost. And then the other thing is, as a consumer, you have to understand, you got to know enough about the field to know what can potentially harm you, what can help you. For instance, there's a company that does hematopoietic stem cell injections, right, for joint pain. They get cord blood, and I talked to I was at a national meeting, and he was trying to sell me their product, and I was just talking to him. He's like, well, we have 10 million stem cells. I'm like, well, what kind of stem cells do you have?
Right, where do they come from?
Where do they come from? He said, well, they come from cord blood. I'm just like, well, you understand that most of the literature suggests that MSCs are the ones that are involved in repairing the musculoskeletal
So again, to
system.
go back to the basics, if you want to grow a bone, a ligament, cartilage, or a tendon, ideally you want something that was
MSC.
Precursor to
That's
build
right.
that tissue. So that's the
MSC.
MSC. Yeah.
So when he's talking about the tenets of cord blood, and cord blood is rich in many, many stem cells, but 90+% of the stem cells in cord blood are hematopoietic stem cells.
Bloodline cells.
Bloodline stem cells. So they're not going to have the same effect as an MSC needs. So I asked him, I said, well, okay, you have 10 million stem cells, but they're not MSCs. And most of the literature suggests that MSCs are really what was effective. And that's Hernico proved that, the bone marrow aspirate proved that, and we have several studies now showing that. And it's just kind of a blank stare. I'm like, your whole company
It's on the wrong principle.
It's wrong
on the wrong
principle. And
yeah.
your provider has to know enough about cell biology, cell biochemistry, to be able to understand which products are bogus and which products have real potential. And that's really what you're paying for. You're paying for someone to have expertise in what you're actually trying to do, so that there's a safety element there, but there's also a hope that it'll be effective. Now, having said that, we still don't have studies.
Right.
So one of the companies
So
I do.
if someone comes in because
Yeah.
you don't have the studies, and
Yeah.
they'll have you finish the later.
Sure.
But if you're going to say, okay, I can tell you that's going to probably be X percentage likelihood of being effective.
Yeah.
How do you quote that, or how do you?
Yeah,
how
so
do you
that
let
and
them
that's
know?
so here's what we do. We can quote national studies. So the case series, the 20 to 40 patients, I can show them those papers. I'm happy to share those papers with them. Sometimes they get bogged down in the scientific language, but I can summarize them and share that with them. So for spine, right, there's several case series, 20 to 30 patients that used bone marrow aspirate to do disc injections and showed benefit. And we can talk about those studies. I can also talk about what I've seen with my own patients. So first 100 patients we did, this was several years ago, but the first 100 patients we did, we called them all and we asked them, did it help? Would you do it again? Would you have your family member do it? And overall, were you happy with the procedure? And interestingly enough, for knees, it was about 70-75% of patients that felt like it was helpful and effective, and they would do it again. And there was about 85% that said they would do it again. So even though it didn't help them, they felt like it was worth trying because it helped them understand
They knew
their
the
options.
potential.
They knew the potential.
If you educated them on
And
it.
it helps us because we track all our data. We do it anonymously, but we're looking to see, okay, what really works and why. So I do bone marrow aspirate procedures, we do the tissue allograft, umbilical cord procedures, and also placental and amniotic procedures. And we track those patients. Does it work, does it not work? So that one of my roles as a consultant for one of the biggest tissue allograft stem cell companies in the country is helping them set up a registry that tracks how all the patients that are doing it. Because
You need to mine that data.
we got to mine the data. And it's going to take me 10 years to get 10,000 patients, right? But if I get all the doctors around the country sending
Share
us their data anonymously, then we're going to know what works best and why. And then we can the goal is then to do the research to prove it's effective so we can get insurance coverage and all that. So it's not that there's nothing being done in this space, it's the push by consumers has been so potent. It's the first time in my career that I've seen that kind of
But
push.
I think a lot of that comes from because of what we talked about the advertising, that there's so much hype out there and
Yeah.
there's so much bad information that they're kind of being sold on this
They are.
dream of it's going to be the cure-all, end-all, and if they don't understand, what we've been talking about, then they're going to have that mentality to keep pushing for it. But again, if you come down to what really is working, what is it really showing? What's your reality of actually having some improvement with this? Then
and patients are
bring it
passionate.
down to reality.
And patients are passionate about it. Look, I have patients that we treated that have great responses, and they're the best advertising, self-promoting thing I've ever seen. I mean, they're excited. They're like, look, I had a very complex problem. We tried all kinds of.
Because that kicked off, can I have you go back to Mexico?
Sure,
Sorry.
sure.
For a third round.
Yeah, sure. So, as a physician, one of our responsibilities is to make sure that we educate patients. We can't just have a quiet voice with something that we don't understand. We have to engage. We have to know enough to know, okay, what is the potential benefit and what are the potential adverse events, so that we don't have patients going to Mexico and spending $20,000 on a therapy that at best won't hurt them, and at worst may do significant damage. So I feel that's an obligation for our profession to do that.
Yeah.
It's uncomfortable, it's a little painful, and it requires kind of stepping out into the unknown a little bit. But if we don't do that, who is going to do that?
Which, for me as a primary care provider, again, is why I wanted you to do this with me and visit with you, because in my practice, I see a small sector of patients.
Yeah.
And I can educate them and say, buyer beware, but there are thousands, 100,000 people out there that are looking at this and who are getting bad information. And so this is one way to extend my reach. By them listening, watching, sharing with their friends, family members who they think might be interested in stem cell or who have been thinking about it, to make sure that they have good information. Because as you and I talked about, a lot of times they're not getting actual true informed consent the way they should be.
And, people can take advantage of that. Look, again, I go back. This is one of the most promising therapies I've ever seen in my career, hands down. The things that I've seen, the research that I've witnessed, I'm very excited about this. But we got to pump the brakes.
Yeah.
Because look, we got to do the studies. We can't be saying this is going to cure everything and all things to all people. There's still a process that we have to go through to make sure we keep patients safe. That requires research, requires informed consent. There's a lot of work. We're just at the very beginning of that. And unfortunately, because there's so much positive energy, and there are patients who have had positive results, in the wrong hands, you get kind of outlandish claims, and you get people manufacturing ridiculous things for that. There's no way they're going to be effective, and sometimes can be dangerous. So it's just educating, and I appreciate you doing this because I think it's very important.
So I have just a few follow-up questions on some of the stuff we talked about. So on the allograft, if I came in and had a consultation done today, what's the next steps for getting allograft?
So the next steps, we contact as a provider or a manufacturer we work with in Salt Lake. That again, I visited their lab. I've seen I know their medical director. I know their process they're going through, and I know the FDA has monitored all their logbooks. So I feel safe with that product. So if someone decides they want to do it, I order the product. They ship it down to us. It has to be frozen at 200 degrees below zero, so it stays in a nitrogen tank that we have in our clinic until they're ready for that procedure. And generally I tell patients, we try to make sure that, we're not doing a hard sell. This is a
Be
small,
sure this is what you want.
Be sure this is what you want, because once I order it, then I can't, unless I'm getting inject money.
Right, exactly.
And it's very expensive. The product is expensive.
Right.
If you get quality product, there's only it's going to be expensive in how you do that. So, and then it's that's for a tissue allograft. With bone marrow, it's a little different. So they want to do a bone marrow aspirate procedure. We usually schedule an hour. Yeah. They come in, we aspirate the marrow, and then we inject that in the targeted areas. So both of those are predominantly what we're doing.
So you're probably doing a consultation visit, and then on either of them, then the procedure and the injection.
Correct. So consultation visit. If we don't have any imaging, then we're going to get the imaging.
Do the workup,
make sure we have a good
diagnosis.
Yeah. So that's a critical part. Mm-hmm. Make sure you know what you're treating. Right. One. Once we're confident we know what we're treating, then we usually schedule the procedure depending on which way patients want to go.
Okay. So now I've gotten my injection.
Mm-hmm.
What am I going to be experiencing immediately afterwards? So what's the recovery? Am I going to be down for the next few days or a week? Or?
Good question. So with bone marrow, usually you get a little stiffness, and this is having done hundreds and hundreds of patients. You get some stiffness for the first couple of days. Sometimes you'll get a pretty potent inflammatory reaction because you're stimulating a repair process, mm-hmm. right? You have initial inflammatory response, then you go to a healing phase. So sometimes up to a week. Shoulders can be a little tender, especially if we're doing rotator cuff injections because we're injecting around the tears, and sometimes there's inflammation there. So I usually tell patients for the first week, anticipate some discomfort. Now, sometimes I'm surprised and they feel better almost very quickly.
But you're saying discomfort, are we talking limiting? Like, if I'm a golfer and I go out every day and I have this done, I'm probably not going to be golfing that week.
I would plan on not golfing that week.
Okay.
And if you can, great. But plan on that.
So it's not going to limit me. You're not going to tell me I can't, but I need to listen to my body.
Listen to your body and what you're doing. Okay. And then usually I'll see patients within 3 to 5 days after the procedure, and that's one, to make sure the pain is fine, and two, to make sure there's no adverse events, because the biggest thing is safety, right? So if there are adverse events, I want to know about that immediately. Then usually I'll see patients about 6 weeks to 3 months. Why? Because this isn't a cortisone shot. You're not going to feel better in 3 days. You may feel better or worse the first week. You're going to start after week 2, you're going to start to get back to where you were, maybe a little better. And then slowly over the next 2 to 3 months is when you're going to really notice it.
So it's interesting. Most patients don't really understand that timeline.
Yeah.
So if you sprain your ankle or you have a fracture,
Mm-hmm.
typically it's going to take you 6 to 8 weeks to heal that. And even after that, you're still going to have some stiffness. And so I had a patient who had a wound the other day. She had a laceration on her elbow. And I said, I was explaining to my medical assistants, at 3 months, the tissue tensile strength is still only
That's right.
90%. That's what's quoted in literature.
That's right.
So
3 months.
yeah, at 3 months, you're still not even 100% healed, even though it looks
That's right.
fine.
That's right.
So you have to realize that when we're doing this injection, we're triggering your body to heal itself.
That's right.
And it's amping it up, it's giving it direction, but you have to go through that healing process. You have to allow that to take place.
And when I hear clinics say something other than that, I get suspicious because look, that's the cell biology biochemistry behind it.
Right. You
You're
can't change physiology.
You can't change physiology.
Yeah.
This is how the repair process works in the body. And what we're doing is we're trying to trigger the body's ability to heal itself. That's what we're doing.
Mm-hmm.
We're flipping it back on so we get that. So it's
that
about
balance coming back.
It's about
I'm talking
it's about
from
2
the
to 3
very
months, and that's
Yeah.
just having done lots and lots of patients, and that's consistent with what my colleagues at Mayo Clinic are seeing. Dr. Chu, that's consistent with doctors who do this around the country are seeing as well. It's not just Dr.
So
Obray.
realistic cell, helping patients understand what they can
Correct.
actually
And
expect.
understanding expectations.
Okay, so we talked a little about who can and should do this. So basically, anybody who has a medical license in the state of Utah could.
That's right. Correct. And you can take a weekend course about how to do a knee injection, and you're a stem cell expert. And I've seen this. So buyer beware. So you get what you pay for, right? You need to do your due diligence. Look,
We should tell patients to ask.
You got to ask.
Where did you do your training?
Where did you do your training? How many of these you've done? And you got to know enough to ask the right questions.
Mm-hmm.
Tell me what you know about MSCs.
Yeah, that was when I asked the patient that I had in my office a couple weeks ago. She was telling me she's going to have this done at an alternative medicine clinic. And I started asking her those questions, what kind of training they have, what are the stem lines, how are they doing it? And she gave me the blank stare, and I was alarmed for her because this is someone who is a senior living off of their Social Security. This is a nest egg that they put aside, and they're going to go spend, I think she quoted me, $7,000.
Yeah,
and she's been doing a payment plan to do it. And I said, I if you don't know the answers to these questions, stop. Stop.
And look, there's something about appropriate pricing too. Because I told you there's a certain limit about how much you can get it below, but some of the prices I see are absurd too. Just because you pay more doesn't necessarily mean you
It's
get
better
more.
treatment, right.
So, but look, if you're going to go buy a car, these procedures are $3,000 to $5,000. Some patients are being quoted $15,000, $20,000. If you're going to spend that kind of money, unless you just have it laying around the house, you're going to do due diligence.
Mm-hmm.
You're going to look at the consumer reports when you buy a car. You're going to look at repair histories. You're going to spend some time to do that, and that's just your car. We're talking about your body, so you got to do your background, do research. Who's doing the procedure?
You'll help me make that analogy a lot in my videos because people will spend so much
crazy.
more time and money on their car in a given year than they will themselves.
And
Yeah.
we need to flip that paradigm.
Yes, it does, absolutely.
Because look, this is one, you don't want to waste your money, but two, you want to have the best chance of success that you can get.
Yeah, and that's something we're pushing for in medicine, transparency in medicine, to make sure that you can have access to the information that you need, that the provider is a quality provider, that they know what they're doing, that they have good outcomes, and that they're going to be upfront with you and help you to have the best results for the best value.
And look, this is not if you're going into some clinic and they're telling you if you go down and do it today, you get $2,000 off, that's absurd.
Yeah,
right?
that's a huge flag
when I
right
hear
there.
that, when I hear pressure tactics and pressuring patients about timing, that's when I do get frustrated. And sometimes I'll make calls and say, look, you can't say that. The FDA will not allow you to say. So I used to do that. I used to get more frustrated early on when I would see egregious things just because I felt like obligated to do that. But now, look, patients have to take the time to understand what they're doing. That's really what it comes down to. And there's enough information out there. And look, go to your primary care physicians. They're going to have knowledge about this, so they're going to know where to find it.
Or they should.
They should. And then ask them, what do you think about this? And get their input. Don't just go off, and otherwise, at best, you're going to waste your money, and at worst, you're going to hurt yourself.
Yeah, we don't want to have bad outcomes.
Yeah.
So I think that you have some great information. I think you can understand what makes Dr. Obray and his clinic different than some of the places that might be out there that you might see advertised. Again, we want you to have transparency and buyer beware. Any last thoughts that you have that you want to wrap up with?
No, I think thanks for bringing education to this area and shining a light on it. I think it's very important, and hopefully we can educate patients and move the field forward. I mean, the goal for me is to get the quality research so that when patients come in, we can actually have good information about what to expect from these procedures. And it's just very early. We're just at the very early cutting edge, and over time we'll get there.
I'm looking forward to this.
And then insurance will be covered. Like I can tell you from what I've seen, this is going to affect medicine in every field.
Kind of like the field of genomics and medicine.
It's going to change
exploding.
everything, and it's very promising. So yes, we're excited, but we're pumping the brakes until we get more information. So and then just buyer beware. Do your due diligence. Ask the tough questions. It's hard to ask your physician. Like I had surgery, and it's hard. It's hard to say, well, how many of these have you done?
Right.
And what's your complication rates, right? Because you want that relationship. There's a respect that goes with your physician, but you have to, especially in a field like this, you have to have that.
Thank you so much again.
Sure.
So until next time, this is Dr. Riley, family physician in St. George, Utah, and Dr. Obray. I would say radiologist specialist in spine and pain.
Exactly. Kind of an interventional in spine and pain. Yeah.
And from Southwest Spine and Pain Clinic here in St. George, Utah. And until next time, Pura Vida.